Hi, thank you all for joining. This is Tim Wiegand. I think I've got the presenter view now. Thank you for joining the fourth Friday today. We just come from a billing presentation, the toxicology clinic to support patients with medications for opioid use disorder. That's recorded if you weren't able to join and are interested in seeing that. We will be continuing in the future with additional clinic and practice support webinars. Today, we've got some guest presenters, which is fantastic. We've got Dr. Lauren Murphy, fellow from Oregon Health Sciences University, will be presenting the first case. Dr. Nick Naka from U of R will be presenting the second case. And then I don't have this in the list. We have a guest presenter, Sarah Weiss and Aaron Gertz from Einstein Medical Center in Philadelphia. Toxicology and critical care fellow will be presenting the third case, and I will be presenting the fourth case. So, Lauren, are you unmuted?
Yes, can you hear me?
You're on, yes. I will advance the slides. Just let me know when you want to advance the slides.
Awesome, thank you so much. So I'm Loren, I'm one of the senior fellows up here in Portland. You can go ahead and advance this slide. So I'm really excited to talk about this case because it was a fun consult that we got. It started out as a poison center call from a cardiac transplant surgeon. She had a patient who was on the cardiac transplant list, and it was a known marijuana user, and their team was really dedicated to try and transplant her. So they had been obtaining monthly blood THC concentrations with THC metabolites with the idea that blood would clear faster than the urine. And so they called with help interpreting these results. And if you could go to the next slide. These are the stats on the patient. So she's relatively young for a heart transplant. Turns out she has congenital heart disease that she had had multiple surgeries for throughout her life and is now at the end stages of what those surgeries could support. And in order to have any sort of activity outside the hospital, she was actually getting outpatient IV milrinone infusions daily in order to have any sort of life. She had a very low life expectancy. She has intact renal function, but the doctor did note that she had mild liver disease, but when looking at her labs, it seems that her liver function is very intact. If you could go to the next slide. So I asked the important questions that we want to know about whenever we're interpreting THC and THC metabolite information. The patient uses marijuana, both inhaled and edible, for help with insomnia, maybe a couple times a week at most. They did not think that she was a heavy chronic daily user. This was something to help her with sleep related to anxiety about her heart failure. It sounded like that she had picked up only a few months ago. And then her last use, this is actually a case from almost a year ago, her last use was April 20th with her friends. And you can advance this slide. On that day, she had both smoked a marijuana joint or cigarette and then had an edible as well on that day. And if you could go to the next slide. So there's a couple interesting things that came up when we were discussing this case. So the question that the transplant surgeon asked me right off the bat to answer was, rather than presenting the case, she just said, hey, what do you know about end-stage heart failure and THC clearance? I was like, wow, I have no idea. Why don't you tell me more about the case? And I got this background. So I wanted to pose this to the group and see what other people have experience with for heart failure just in pharmacokinetics of other drugs, and then if anyone has the experience with like what heart failure would do for the clearance of THC and its metabolites.
That's great. So if you've got a question or comments, just raise your hand. I see Richard Tovar has got his hand up. I'm going to unmute you. Go ahead, Richard.
Well, it's obviously all about GFR, creatinine clearance, and so I'd want to know what that was, and what other medications is this individual on, and when does she have the active metabolites of the THC in her system, and edible versus smoking? How much is of which? Those types of things.
Sure. I think those are all things that I asked the doctor as well. We do not have a good ratio or how much of the marijuana contents that she's using, and we don't have the percentage THC of those compounds either. Again, it sounded like it was spare use, maybe one event of intoxication once or twice a week. But this could not be verified, and the transplant surgeon had a hard time getting this information from the patient. Regarding her renal function was perfectly intact. I remember her GFR being greater than 60, and she had a good creatinine clearance as well. So her renal function can be presumed to be perfectly intact. Unfortunately, I did not get a full drug list. The only thing I knew that she was on was milrinone. So I don't have an idea of, I'm sure you're alluding to, other drugs that could inhibit metabolism, like marijuana is metabolized by CYP2C9 primarily, with a little bit of CYP3A4 and maybe another, but I didn't have any information on other CYP2C9 drugs. I hope I addressed, I think that was most of the questions that you asked.
Yeah, thank you. That's me, Richard. I unmuted you again. Did that address your questions, Richard?
It sure did. And yeah, especially the P450 inhibitors would have been interesting.
If there aren't more, oh great, yeah.
Quick, this is Tim. What was her body habitus? Did she have? Lean, a lot of fat. What was her body habitus like in BMI?
Great question. Her BMI was 28. Unfortunately, this was a phone consult from out of state, so I didn't get to personally examine her. But from what I ascertained from the physician is she has a terrible burden of peripheral edema, and it was difficult to get an idea of fat content and lean muscle mass. We just knew that her BMI was 28 based on her weight, but it sounds like she was quite deconditioned because of her end-stage heart failure. A really important question, but definitely difficult to answer with this disease.
Sure. Thank you. I don't see other questions or comments, so go ahead.
Great. You can go to the next slide. So the next question the physician had was the question of whether her stage 2 liver disease should affect her clearance. I think we're pretty comfortable as toxicologists answering this question because we get asked this a lot with other meds. What I was able to find was that stage 2 liver disease really shouldn't impair your metabolism. You're not losing the function of your CYP enzymes or your phase 1 or phase 2 systems until really you hit cirrhosis. So for our standpoint, we took this off the table. I don't know if anyone else has other comments, but we really didn't think the stage 2 liver disease with intact INR, intact albumin production would be affecting her clearance.
I don't see any hands up, but if you have a question or comment, please raise your hand. But I agree, I wouldn't have thought that would have affected her clearance.
Great. So we can go to the next slide. I did find just a quick, interesting tidbit, which was, of course, a case report, not a case series or any objective, large randomized data, but we do have this case of cirrhosis causing incredibly prolonged THC and THC metabolite clearance in this patient who is actually under a similar situation, undergoing evaluation for a liver transplant for alcoholic-induced end-stage liver disease, who also heavily used marijuana, about 6 to 8 marijuana cigarettes daily. And so his last use was at day 0 on this graph, and they were monitoring both serum and urinary metabolites, and he was testing positive. They were very, in the paper, of course, the main problem is this guy reliable? Is he not using? But he was subject to random blood and urine tests with several hours notice, and he was testing negative for all the previous drugs he abused, including alcohol, but his marijuana stayed positive and was actually detectable up to 350 days from his reported last use, which is, I just thought, interesting background, but, not as applicable to this case. So with that, I will finally show the test that I was asked to interpret. So you can go to the next slide. So I'm sure that's what we all want to analyze now. So she had 4 months of data. Day 0 is the April 20th date. She was getting blood concentrations only. The THC was persistently below the serum cutoff, which was 5 nanograms per mil. Her carboxy-THC metabolite was elevated the entire time, but steadily decreasing after day 60. Now, what's also interesting to note is that this test involved 4 compounds. So the THC, the hydroxy-THC and carboxy-THC metabolites, and also cannabidiol and cannabinol. And the 3 that I noted on the right of the page here were persistently negative at every single check. And those had a confirmation threshold of 1 nanogram per mil. So one of our metabolites is always negative. Let's see. Yeah, so this is what we were asked to interpret, and I would be very curious to see what others have to think. Is she still using? Is she very strategically using her marijuana still and stopping a couple weeks before her check? These were not random checks. They were scheduled monthly, so she knew they would be coming up, and I wanted to see what others thought about interpreting this data.
Sarah Weiss has her hand up. Go ahead. I've unmuted you.
Hi, Loren. The serum cutoff threshold, is that the detection cutoff or what is considered abnormal or positive?
It said serum cutoff threshold on the lab printout. So it didn't have like reference range less than 5. It just said serum cutoff threshold, which made it, I was very confused by that as well, because usually we're used to, in interpreting like a reference range. But that was also a question we had is should these tests below the cutoff be disregarded, as the test should not be reporting these? And should it just be listed as less than 5? And that was one of our questions too. But unfortunately, this is what the lab was presenting with. And insurance was saying, of course it's insurance, right? It's not the doctor deciding. But it's the insurance saying, well, she still has positive values, so we can't validate her for her last day of use.
Yeah, we've had some interesting lab results like that as well, where we'll get a reported level that is below what the lab tells us they can detect, and then we'll say, but you can't detect less than 5, and they say, but it's 3. And we say, but you can't detect less than 5. So it kind of like does this round and round situation, and I wonder if maybe that's what's happening with that lower level there, is that they're reporting a level that's actually below their detection limit, because that would not be, it's certainly something I've experienced before.
Those were very similar.
I've seen that happen when you have a panel that if one of them becomes positive, it triggers a confirmation and a result that then automatically does a confirmation and a result on all of the things in that panel, even if they were below the first threshold of detections. Then you start to get the values for things that were initially negative but are in fact there. I've had that happen in fentanyl a couple of times when we've had, I think, a false positive, but then there's actually been fentanyl, small amounts there. But I think that's probably what's going on, and then they're giving you values because they've actually run the GCSF, which will pick up at the lower level, but that can be very frustrating. Anybody else, any other comments or questions?
I would love to hear if anyone thinks they can, because we were asked to decide, what was her, can we say that the day 0 was her actual last day of use? And I'd love to hear if anyone has an opinion on whether you can make that decision. I know you don't have as much time to decide as we did, but we had some people on both sides of the fence, and I'd love to hear other opinions on whether we think she's still using.
Richard, you still have your hand up. Do you have a comment, or is it just left up?
Nope, sorry, I'll try to take it off.
Okay.
So this is Nick Naka, sitting next to Tim here. Maybe it's a little naive. I feel like I've dabbled into some of this literature, but I've heard discussions about the THC to THC metabolite ratio being potentially used as possibly trying to determine whether or not a patient was acutely intoxicated in the courtroom. And in looking at this graph, I mean, the THC to carboxy THC ratio has actually gone up, right? So I don't know. I think this, to me, it seems very unlikely that her last day of use was as she's reported, and that there is some continued exposure. I wonder if there was any, CBD product, or I missed part of the introduction, but I wonder if maybe, okay, I stopped using THC, but I've been taking the CBD oil, and maybe there's low-level THC in that, and that's where the continued levels are coming from.
That's a great comment. I was wondering that earlier. I didn't see reference to that. If there was, I missed it. It was work trying to run the slides, but the low-level THC in some of the CBD products would be really important to rule out.
From what we heard, she was not using any CBD products. I also came across that study and tried to help use that to interpret this data. It's also interesting in some of the very few studies that exist on using edibles, they report very interestingly that often after edible use, peak THC, the parent, is often less than 5, even during acute intoxication with 50 milligram brownies in this one study by Vandre et al., which I believe I included in the references, and the carboxy tends to be higher. So again, this is very difficult. I wanted to be on the patient's side, but then I don't also want to miss this idea of terminal excretion. She does have terrible, like I said, she's on IV milrinone in order to support her function daily, and she has very little blood flow to her. In general, it's decreased to her liver, though her liver's still functioning. But then again, she has these steadily declining levels that would be hard to mimic by purposely using THC at the exact appropriate time unless she's using daily and these just happen to be what she always looks like, which is hard to tell because we don't have the data from previous, of course, to compare to when she's using recreationally, therapeutically. Any other comments?
I don't see any other hands raised, but I have to agree with Nick. I think it's very hard to determine. One of the things that I recall looking at with the ratios is you get down to very low levels. I mean, the THC levels are at the end are close to 1 nanogram per milliliter. I think that even though the ratio's greater than it was 37 days after the last use, 60 days after the last reported use, it's very difficult to interpret because the levels are so low at this point. I would be hesitant to base the ratios increasing because it indicates that there's more recent exposure. In light of that, I think I'd have to go back and look at the literature, but I think that the elimination of very, very low levels can persist in particular if there's a lot of obesity and lipid stores.
I agree, and that is the way we ended up reasoning through our case in the end too, that she's so low and we simply do not have information. I mean, 100 days is a very long time to be positive. And again, this Brownie study by Vandre et al., which was genius and really fun to read, people were clear by about 60 hours and not 100 days. And that's edible too. And so it's very difficult in this patient. But for sake of time, we can continue on to the next slide.
I've had patients that were heavy users, continuous heavy users with a lot of adipose tissue that were positive for several months by THC to creatinine ratio. We weren't looking at all the metabolites, but clearly trending down to very low levels with very frequent urine tests for court for into the 3rd and 4th month. But that's not that common, but that's after heavy use. Next slide.
Yeah, it's very difficult to say. So we touched on this a little bit. Generally with, I think the main point I wanted to bring up again, was just that with edible use, your THC will often not go above 5, which confounded how we interpreted the results because she's using both inhalational and edible. And again, we're stuck with this patient because even though her BMI is moderately elevated, we have no idea what her fat content, lean muscle mass is just because of her really terrible heart disease. And we can go on to the next slide too. So before I end with our decision and the outcome of the patient, the other thing that was really difficult in this case was insurance is telling this patient that she's, positive when she has a parent compound that is below a threshold cutoff. And what was also difficult was this team was getting blood counts when in general we use urine to clear the patient. And so this really philosophical question came up with, what is negative? Should we do it by urine? Should this be standardized? Should it be by blood? If you're at terminal excretion, does that count? Or do you really have to wait till this patient has a 0 value for every metabolite? Should we use the Department of Transportation that guides our urine drug screen cutoffs, or should we change these to make them medical? And I don't know if anyone else has any thoughts, but I think that really made this case difficult too.
Those are some great questions, and so we've got Beth Bilden has her hand up. I'm going to unmute you. Beth, go ahead.
On the sort of philosophical side of things, adding to that or included in that is that, there are these national transplant guidelines, which are healthcare as well as the public. They each contributed. And at this point, my understanding, I know there's some new ones in 2019. I haven't looked at those yet, but there are guidelines, and they say that you need to be drug-free, whatever the testing is you choose, but drug-free for a certain number of months before you're a transplant candidate. But the two things, one that you mentioned is it was the insurance in this case. So you have a transplant center that says we're willing to do this. They're waiting till a negative comes up, right, and for a certain duration of time probably to meet insurance guidelines. And then there are these national guidelines as well. But my understanding, and maybe you could elaborate or in some way on this, is that the centers get to decide. And that's based on a 2017 case that I was actually called about, who started in Salt Lake City. They called multiple transplant centers in the country, and the one that ended up taking this 20 or 19-year-old at the time was CHOP, even with a positive drug THC or THC equivalent test. So I guess I'm asking, again, just in general about some of the philosophical stuff, and how did this play out? Was it really the transplant centers interested, and are they doing this testing because the insurance company is requiring it, or their center, or both?
Yes, that is a really great thought, and I talked to the transplant surgeon about this. She said she was not concerned about this patient's drug use or how it would affect the patient, and she was ready to transplant the patient at any time. She had known her for many years and had been working with her and trusted her and believed she was a very reliable patient. This was mostly an insurance issue. We didn't get into the institutional question, and that's something I could have asked the transplant surgeon. So thank you for bringing that up, because those are a couple points that I can use when I'm discussing this with consultants in the future. But I know that insurance was an issue because they wouldn't cover it, and they were trying to stem the patient along to survive long enough. But interestingly, it sounds like there was an institutional component, and the cardiac surgeon noted that she had had 2 other patients die while waiting for a transplant because their marijuana tests were still positive and they couldn't list them early enough.
Yeah, that obviously seems to be, especially nowadays with a number of states with marijuana being legal. It'll be interesting to see how this plays out. Thank you.
Absolutely. And I want to save time for the other presenters so we can go on to the final slide. And I'll just let you know, so we decided again, like we talked about earlier, that because the ratio, even though the ratios between the THC and metabolite were increasing, because they were so low by the end, we decided to say that we trusted the patient and that April 20th had been her last day of use. I called the surgeon 6 months later to see what had come. They said insurance accepted our answer by consulting with us, and they provided our toxicology record where we stated, we interpreted the results and interpreted them to be declining and consistent with the patient's story. She was successfully transplanted afterwards and 3 months after this, and then had a very improved course. But by the time I called her, she was having her first episode of graft versus host disease, but they did transplant her, and she had been doing well after that. Thank you, everybody, for listening and contributing.
Yeah, thank you. This was a great case and brought some previous consultations that we've been involved in to mind. Usually they're related to opioid use disorder and helping to stabilize that while the patient then either goes into a treatment program to get the appropriate length of time that's required by either the surgeon, or it seems more frequently that it's the surgeon driving that rather than the insurance, but we may just not be fielding those calls. We did have one comment that or suggestion from another attendee that was to start the patient on Marinol. Problem solved, though passive aggressively, but I don't know if there would have been an option for doing that or not, but certainly it seems like we've had cases that have been THC positive here that have been transplanted. I will have to go back and look. That would have been in the context of other substance use, but again, a great case. All right, Dr. Naka is going to take the second. I'll advance the slides. Go ahead, Dr. Naka.
This is a very challenging case we've been managing over the past month or so as a 34-year-old gentleman with a history of opioid use disorder and cocaine use. We were consulted when the patient was brought into the hospital and found to be bacteremic. He has a history of endocarditis with mitral valve repair in 2016. In 2018, he had a cardiac arrest and had a pacemaker inserted. He'd been maintained on buprenorphine 2 milligrams sublingual 4 times a day, which was held and actually administered to the patient by his mother. He had been working as an electrician and doing well, hadn't used IV opioids for over a year, but had a single isolated relapse with cocaine 6 months prior to admission to the hospital. He's growing Staph aureus species in his blood in I think that's actually in February of 2020. His initial report was that he had had a dental procedure for which he had not had any prophylactic antibiotics, and I thought I'd kind of open it up right there. This gentleman presented himself. He's very articulate, very intelligent. He'd been living with his parents. He'd been doing well, according to his family, actively, working and engaged in society, and a lot of people were inclined to believe that the bacteremia was not related to a relapse. So I guess I wonder how most people would interpret this presentation.
Thank you. Go ahead and raise your hand if you've got a comment or want to weigh in or chat. Let's see. The Emory group or Joseph, I'm going to unmute you and see if you can weigh in on this.
Yeah, I guess just to clarify, Nick, you're saying this is Staph aureus or Group A strep?
Staph aureus. Sorry, what did I? Group A. I'm sorry, Staph aureus.
Okay. I mean, I guess I think of Staph aureus more commonly as a skin and soft tissue infection than as something that would come from the mouth, which would be more like strep or anaerobes. Is there any sense that this patient had any infections at all recently that he admits to, or any pimples he popped, anything like that?
The only thing he says is that he's an electrician. He's constantly working with his hands. He constantly gets nicks in his hands, and that was the only thing that we could gather.
Okay.
Yeah, I think your question though makes the point that Staph A shouldn't come from a dental infection, so that's kind of off the table. I think you could probably go to the next slide, Tim. And after meeting with this gentleman, this is just his urine screen, which was negative. Next slide. We recommend continuing his buprenorphine, obviously, during the hospitalization. On hospital day 5, the team told him that he could get his 6 weeks of antibiotics as an outpatient, but on day 6, the infectious disease team said no, you can't do that. You really need to stay in-house. And, I think on the next slide I went to bat kind of, after interviewing the patient. I believed him. There was some part of me that felt like he probably had a recent relapse, but given his high functioning, given his his negative urine screen, he didn't have any withdrawal, he didn't have any signs of intoxication in-house. I felt like if anybody could receive outpatient IV antibiotics for bacteremia, it would be this gentleman, obviously under careful follow-up. And so that's the conversation I had with infectious disease, and infectious disease said, listen, we're the ones prescribing the antibiotics and managing the line in the outpatient setting. We've been burned many times before, even though that this guy seems to really have his act together. We're not comfortable with continuing antibiotics as an outpatient. I thought I'd ask if other folks run into these circumstances in the hospital. It seems to be a very regular occurrence for us that we have on any given time 5 or 6 patients in-house for protracted antibiotic courses, and they're really only here to receive IV antibiotics. Anybody else experiencing that, or are they able to send some patients home with PICC lines?
Joanne, I'm going to unmute you. Dr. Lace, do you have any comments on what you're doing in Minneapolis?
As far as the PICC line goes, we are talking with the PICC line servicers of our area to loosen up their regulations, because I think what they were doing was saying that anybody who had used IV drugs in the past 6 months wasn't able to receive a PICC line. So we are still pretty limited with doing a PICC line for somebody that was recently IV use of drugs. The infectious disease team has been going to second line oral regimens instead of the preferred IV regimens. The other thing that we have done is we've created a high-risk infectious disease committee where it's the cardiologist, the infectious disease specialist, addiction, and then whatever the primary team is to discuss the management of care in the hospital, especially when they're going to be there for 6 weeks and are at high risk of eloping or drug use in the hospital.
Yeah, that's great. This is Tim. We've had a lot of discussion around that because there's a lot of variability by hospital. We have a sister hospital versus the strong, and by floor in particular. And there's a lot of inconsistencies and different ways that people handle this and handle relapse and use in hospital. I have to say, in the last couple of years, there's been different groups that have wanted to set a separate unit at a skilled nursing facility or at a nursing home that would be able to admit the patients with outpatient treatments actually coming into the units, so patients for prolonged antibiotics would then get some counseling and other support. And that hasn't materialized, but I know people have still discussed that. The hospital here is also looking at a separate unit to house the patients that require prolonged antibiotics and other care, which would be somewhat associated with the psychiatry units, and it'll be interesting to see how that works out, because whether or not they could leave the hospital or not at all while on that unit, it comes up. So there's a lot of questions that arise with this. It's very interesting. I met the patient initially, and my impression was he probably relapsed, but seemed to be doing really well overall. He was working, functioning, and his parents were like devastated that this happened. And so there was kind of that as a factor, trying to go to bat for him in terms of he's doing well. This happened, and it may have been a skin, something with his skin. But, I think I also, when people, I'm concerned that they may be injecting their buprenorphine, hesitant to put patients back on it, although in some cases we have to do that because that's really the only option. But suggesting methadone or extended release naltrexone or now Sublocade, we have a different option at least. This gentleman was taking it 4 times a day because he had terrible pain in his fingers when he had the mitral valve associated endocarditis. He had embolization into his digits and auto-amputated some of the tips of his fingers, and so he still had pain from that episode as well. He actually had a stroke, I believe.
Yeah. So I put a lot on this slide, but on hospital day 14, we checked in with him. He was doing well, no complaints. And then on hospital day 23, nursing caught him with a syringe in his bed, injecting something into his PICC line, and he quickly jumped out of bed and threw the syringe and got caught injecting. And so we saw him the next day. We had a long conversation with him. He kind of was doing a Dr. Jekyll, Mr. Hyde kind of thing, where he was going back and forth about how he knew it was a relapse, but he was frustrated that the nursing staff was leaving syringes lying around. Felt like that was a trigger for him. Basically, we decided, we left with recommendations to continue buprenorphine, but have close observation and educated nursing staff on how to observe the dissolving of a strip under a patient's tongue. On hospital day 25, nursing notes that it looked like he had tampered with his PICC line. And hospital day 26, he was found after the nurse administered his sublingual Suboxone to have quickly pulled it out of his mouth and stashed it into a urine cup that he had kind of hidden in his pants. And he did it so quickly, the nurse says she just turned around for half a second. When she looked back, she caught him fidgeting with his pants, and that's how they found him with the urine cup. And so we counseled him again at length, and finally he was able to admit that he really had developed a problem with injecting Suboxone, which I think was a big step for him as far as his addiction goes. And so, where to go from here? As Dr. Wiegand mentioned, we tend not to continue outpatient sublingual Suboxone in patients who've begun to inject it because it seems that they tend not to do well. I've heard people with alternative viewpoints on that, but we talked to him about methadone and we talked to him about Sublocade, and ultimately the plan is going to be to discharge him with close follow-up to his primary care physician, who's also a medical director of a chemical dependency treatment center, who's going to try to have close transition to Sublocade. Obviously, there's some issues with insurance, and actually executing that is not going to happen as seamlessly as we would like. And our P&T committee is not going to really allow us to put Sublocade on the formulary based on the fact that it's really thought to be an outpatient medication. I think we're going to have to do continued close observed doses with the family in the transition to Sublocade.
Yeah, that's very interesting. Thank you. We'll have comments in just a second. I'm wondering how did you interact with his parents? Did he want his parents kept in the dark, or?
So far, we haven't interacted with his parents. We're going to have to at some point with educating them on how to do careful observations of how to watch him, make sure he dissolves it under his tongue. I suspect that he was cheeking his medication even prior to hospitalization, and that's probably how he originally got bacteremic.
I'm surprised at the flora that he had then, but I guess he was injecting after cheeking pre-hospital. We've had a couple of cases, well, one that I know from the hospital, a separate clinic, a medicine clinic, had a buy and bill option for the Sublocade and was able to not administer the shot on the day of discharge, because apparently you can't see the patient in an outpatient clinic and then bill for it and then bill for the medication on the same day you're discharged from the hospital. But they did bring the patient back very quickly, like 1 or 2 days later, and give them the Sublocade. But I've only known that to happen once. Maybe that's an option. We can look at that. But any other comments or questions regarding this? Dr. Bashevitz, I see you are on. I'm going to unmute you. What do you do with your patients when you find that they're injecting the buprenorphine?
Well, so we would have that same plan as well with either Sublocade or perhaps methadone if they needed that. We would put this particular guy, in a stabilization program where he could be observed taking his buprenorphine until such time as we could get the insurance approval for the Sublocade.
Thank you.
Lastly, just go to the next one. The PIC line nurse was actually a previous, I don't know if she's a CASAC, but she worked in addiction medicine at some capacity, and she came up with a makeshift device to try to prevent in-house tampering. And so if you go to the next slide, there's a picture of what she did. Basically, that's your PIC line, and she has gaskets over the cap, and then she slid a 5 cc syringe over that, and that all gets taped and initialed to the patient's chest, which I thought was clever. Apparently, they do make commercially available locks for PIC lines, but they're $40 a piece and they're one-time use. So that's not really a good long-term option. But this is a pretty ingenious method of trying to add another layer of security.
Yeah, that's great. I think I've left someone still on mute. 1 second. If you're unmuted, just go ahead and mute yourself. Go ahead, Nick.
No, that was all I wanted.
That's really neat. That's nice problem solving solution for that, at least. So hopefully it doesn't tamper again. I'm, again, surprised he didn't have oral flora. Has he had any blood cultures that have been positive here, spiking fevers?
Not since.
It's lucky. So, all right, we're going to move on to the third case. That's Dr. Weiss and Dr. Gertz. And are you unmuted? Let's see if I can find Dr. Weiss here again. I think I had you unmuted earlier, but...
Hi, can you hear us?
Yes, I can.
Hello.
Yep,
I'm Dr. Weiss.
I'm Dr. Gertz. Nice to meet you.
So we'll just, I guess, jump into the case presentation if you want to go to the next slide. Do you want to start with what she looked like? Oh, the formatting is all kinds of screwy. Oh, well.
I tried to fix it. I think that all of the text should be in the slides. I realized that as I connected the two, but I should have all of that, all the material on there.
That's okay.
Yeah, so I initially evaluated this patient in the emergency department. As you can see, she's a 60-year-old African-American woman that came in with shortness of breath and essentially COPD and URI symptoms, cough, productive sputum, shortness of breath. Pre-EMS, you can see she was hypoxemic, around 70% on her home oxygen. She's a fairly severe COPD patient, Gold D, high stage as well. In addition, though, she also has multiple chronic pain issues, primarily musculoskeletal, and then a cardiac history with atrial fibrillation and hypertension. Unfortunately, also a TA and a bit of medication and treatment non-adherence. Additionally, she reported to me that she had some substance use in the past. Throughout the course of the evaluation, described as cocaine, and she did describe to me some opiates. And there was one mention of heroin. However, given her acute presentation, she couldn't give me a time frame of when she had last used when I saw her. In the initial evaluation, she was in distress, respiratory-wise, tachycardic, very hypertensive, and obviously hypoxic until placed on BiPAP, after which she improved. Her physical exam was consistent with acute exacerbation of COPD. In addition, her radiology was also consistent with the chronic picture of that. The main important labs for this conversation, you can see, are her blood gas, which show an acute decompensation with her hypercapnia and her hypoxemia. In addition, she did have a UDS performed with the positive that you can see there. The only other thing that I would add here is, in my first evaluation of her, she not only appeared to be a patient with a respiratory exacerbation, but she was very anxious. And she, confided in me that she was feeling very anxious and worried and actually fearful. So that was one thing that kind of painted my interactions with her initially.
I don't know if you guys can see down at the bottom. At that time, she was adamant about being DNR, DNI as well. So you can go to the next slide. We'll have our first 4 days of her clinical course, and you can go to the next slide again.
So initially, I admitted her to my intensive care unit, placed her on BiPAP with titration. Her hypercapnia improved with a little bit of post-hypercapnic alkalosis, basic COPD management. Shortly thereafter, she was stable and transferred to our step-down unit. There, I physically wasn't present for her course for a while, as I'm strictly in the intensive care unit. But per the reports and the documentation, she had continued to complain of her chronic pain issues and some acute on-chronic issues, in addition to her anxiety on top of her respiratory issues.
Go ahead.
What's that?
You just cut out for a second, but came back in. Sorry.
Oh, good. Okay, sorry. Medically, she also had other complications, including atrial fibrillation. She had RVR during her admission, and a few different back and forth episodes with her medical destabilization. She did eventually decide to change her code status. At that point, given a repeat episode of decompensation, acidosis, and hypercapnia, she was intubated.
Next slide. Yeah. So she self-extubated herself about 24 hours after that.
Yeah, so she did self-extubate herself very quickly, unfortunately. And again, eventually the same story. Once again, she kind of stabilized after her hypercapnic acidosis and her respiratory issues were addressed. She went back to my step-down unit, and again had complications with her atrial fibrillation, but also her anxiety. You can see here in a quote, she was transferred back down to the step-down unit, even from, I believe, a GMF level of care for her anxiety kind of feeding into her distress. And one of the providers even felt that her anxiety was a major contributing factor to her respiratory distress, in addition to some pain-seeking behavior.
Next slide. Yep. What?
So in the ICU, as I said, she received kind of a lot of standard treatment, BiPAP for her acute hypercapnia, standard nebulized treatment with steroids, with Solumedrol, but more higher interval than usual. Throughout the course, she did receive a few other things, including some Ativan one time for agitation. She had been placed on Precedex also throughout her course for weaning and agitation. Same thing with the Seroquel, clonidine, in addition to management for her atrial fibrillation. And then throughout the course between step-down and ICU, she had actually ordered some tramadol at one point. Next slide. So unfortunately, one of the themes of this case was a lot of back and forth. And once again, she had refused her BiPAP overnight with an anxiety component. And she had decreased once again in her pH with a hypercapnia, this time with some opacity suggestive of pneumonia and leading to her reintubation again. Next slide. So initially, thank you. Initially, we were going through kind of our standard protocols with sedation, including fentanyl and propofol. But one thing that I noticed actually is that throughout this back and forth course that I mentioned, she had been getting very variable and intermittent opiates and other analgesia as well. She had periods where she would go 24, 48 hours or even more, where somebody would give her something and somebody wouldn't, before she eventually had that second intubation, and then ended up in my intensive care unit where she was receiving some standard sedation. And even that had been held during her breathing trial, which kind of led to a curious thought of mine. At one point, we were doing a breathing trial, and I was rounding with my team, and I noticed that not only was she extremely agitated, but she was clearly anxious. While intubated, it made it a little bit hard to, have an actual interview with her, but diaphoretic. She had some goosebumps, a piloerection, and, other things that were concerning for possible withdrawal. And while I deal with delirium of all different sorts virtually every day, given the experience that I had with her previously and in my evaluation, I actually asked myself the question, could this all be, because of this back and forth, this patient going into withdrawal and making this management even harder? So I have a pretty reasonable relationship with my ICU and the toxicology department here, who also frequently manages our substance use disorders. So I contacted them and I asked, was there anything that you think you could help me with in this regard?
So if you go to the next slide, obviously, Aaron let me make the slides. Next slide. So this is where I got involved in the case. I did a little extra sleuthing to figure out what sort of her past medical history was and what was the deal with this, was she was using her sister's Percocet, or was she using heroin, or what? And I found she had in her prescription history, someone had prescribed her a Narcan intranasal kit, and I tried to call that prescriber, and they unfortunately never called me back, so that was not very helpful. And so when I went to see the patient, she was very calm and sedated and had no signs of withdrawal because she was on 200 mics per hour of fentanyl. So I paused just the propofol, and I left her on the fentanyl, and she started to wake up, but was very, very calm for me with no agitation or anxiety for the whole time I was sitting there watching her. So go to the next slide. So based on, my assessment of her prior record and her visit to this admission and prior admissions and things like that, I made these recommendations. I had heard Dr. Wiggin actually talk about buccal induction in intubated patients, and I had really no idea how to do it, but I thought I'd give it a shot. So I did a buccal microinduction with her. So we gave her buprenorphine 1 milligram every 6 hours times 3 for the first 24 hours. I gave the ICU teams and the nurses some really careful instructions about signs of precipitated withdrawal. They did this while she was on fentanyl. And then I did advise them not to restart her dexmedetomidine until at least 1 hour after the first dose of buprenorphine, because I didn't want to potentially mask the signs of precipitated withdrawal in an intubated patient. And so this was kind of me just trying to make a protocol, I guess, for something that I had heard about but never personally done. Next slide, please. So the next day I saw her, and I'm just kind of quoting myself for what I had seen, was that she actually did really, really well. She had no signs of withdrawal with that first 3 milligrams. And then I spent a lot of time talking to the nursing staff because they were very involved with her, and they had known her through both of her intubations, depending on which nurse that she had. And the nurse said that she was doing a lot better. So that kind of emboldened me to keep going. So I increased her 2 milligrams every 6 hours. And what Aaron had told me when he first called me was we'd like to have her extubated within the next 24 hours. That was the goal. So I was kind of directed with this idea of okay, we're going to help her agitation and her anxiety, and she's going to get extubated. So next slide. So day 3, she was doing fantastically in terms of her anxiety and her agitation. She had no signs of withdrawal. She had gotten off of the fentanyl infusion, but then she developed this secretion problem. So I had gotten her up to a total of 8 milligrams, and she was very redirectable and awake in kind of the way that we like to see intubated patients. So I kind of concluded that opioid dependence had been taken off the table, but she had a lot of secretions that prevented extubation. They continued her. Next slide. So this is the part where there was a lot of back and forth between me and Erin. I left her on 2 milligrams Q6 buccally for another 7 days. Do you want to talk a little more about her on this regimen?
Well, I think the thing is, on this regimen, actually, for this part, she actually did fairly well. As Dr. Weiss was saying, the nurses were reporting that she was doing better from a kind of a what we could read as an anxiety and agitation standpoint. And there really wasn't in terms of her anxiety, agitation, and sedation, as much of a roadblock. There's back and forth, as there is when you're trying to wean somebody off of a ventilator, obviously. But in terms of this regimen, it actually went very well. Unfortunately, she had very profound high-frequency suctioning secretions that made it very complicated to extubate her. So, and that became the real roadblock.
So we'll kind of get through the rest of this quickly. So next slide. On buprenorphine day 9, she was successfully extubated. She had only been getting fentanyl pushes on the night shift, which I found kind of interesting. For some reason, she was just calmer during the day, but she hadn't gotten any opioids besides bupe for 48 hours prior to extubation. Next slide. After extubation, we have a quote from one of my co-fellows that she continues to state the last time she used any heroin or other drugs was 6 to 7 months ago, and that the buprenorphine was improving her cravings. But then if you go to the next slide, later that exact same day, she said, no, this isn't helping me at all. I don't want to be on it. I'm not a drug user. I don't use opioids. And so she wanted a taper. And so we initiated a 5-day taper. And every single day we confirmed with her that, no, she did not want to be on this medication. Next slide. So hospital day 24, she was discharged to SNF on no opioids at all. And it says 2 admissions for COPD since, with the caveat that actually she just checked into our ER this morning. So that's 3. I was hoping people would sort of chime in with their thoughts on this management, unless you want me to go on and talk about some of the literature that I know of.
No, that's great. Let's take a break and get some comments. I think there's several people that are in attendance that have done microinductions, and it was interesting that you mentioned, you heard the use in intubated patients. I think it was at the ACMT conference a couple of years ago we had a series of patients that were intubated, were stopping the fentanyl or short-acting opioid, waiting about 6 to 8 hours, and then doing an induction when they tolerated the wean the starting dose was off and a half of the 2 milligram film about 6 to 8 hours after the fentanyl had been stopped. Then they tolerated that, which was the starting dose for your microinduction. Our microinduction, we go a lot lower as the first dose and go up, but I'm wondering if, and I can talk about that a little bit, but I'm wondering if other comments, Nick, you had.
Yeah, I would just say, well, 2 things came to mind during the presentation. One is, I think that I would be an advocate for a little slower of a microinduction. The one that we do typically takes at least 4 days. And the reason for that is I think that there's a lot of variables when you go to apply this to different patients. The dose of full agonist opioid that they're on and as an infusion while they're intubated is going to be different, as well as their dependence level is going to be different. And we do know that that harm can be done with precipitated withdrawal. So in effort to minimize harm, when doing a microinduction, I'm an advocate for a slower induction, which requires dosing sub-milligram really on the first day. And for that reason, you have to have on formulary a different preparation. You have to have a belt bucca presentation for 450 micrograms, which can be a hurdle for a lot of people, but I think it's important. And then the other thing is it does bring up, and was subtly brought up at NISAM this year too, the idea of starting somebody on buprenorphine without discussing it with them because they're intubated. And I think where I've settled on that, if it's for if you're struggling to extubate the patient or struggling to sedate the patient, I think it's totally appropriate. But if you're just doing it because it's kind of what's the word? It's an opportune time to start them on buprenorphine while they're intubated, I think that's probably not the right time to do it. Obviously, this case you presented is not that case. That this patient clearly there was issues with sedation, but I think those are the 2 points I would bring up.
Henry Swoboda's got his hand up. Go ahead, I've unmuted you.
Yeah, I mean, my one point, we have IV buprenorphine on formulary, so we can give kind of smaller doses that way. But also, we've done a couple off of methadone, and we can't split our tablets any more than to get, less than 1 milligram. And so when we're doing our kind of micro inductions off of methadone, we start with 1 milligram and haven't had any problems with that. So I guess one of my questions to the group is, have you guys seen it go wrong where you give 1 milligram to people who are on a fentanyl drip or something like that, and they have an adverse effect? Because I agree that in the past when I have tried to do microinduction and that sort of thing, we try and give like little tiny doses of the IV and then maybe shut off the fentanyl drip and wait for a while and don't do this cross taper thing. I wonder if we're being too cautious. If it's working with the methadone patients to get 1 milligram twice a day, then I wonder if it would work for our fentanyl patients.
It's an interesting comment. There's a paper out. I think it's a description of a process a guy names after himself, the Azar method, that you start buprenorphine with methadone and you continue the methadone and go down and you increase the buprenorphine dose, and he starts at a pretty, not a ultra low dose. I have had patients that have started 1 milligram in the outpatient setting after, cutting a 2 milligram film that we wanted to try an induction when they didn't really look like they're in withdrawal, complain of subjective symptoms and get kind of spooked. Whether or not, if they're intubated and you've got some other sedation, you can easily tolerate that. I'm wondering really how quickly we can go because, you can use the adjunctive meds. You could continue the Precedex or the clonidine. That was held as interesting. We'll often just leave everything else on and look for symptoms if they're over the sedation, but again, start much lower. We do have the IV buprenorphine. One other suggestion is to leverage the reduced bioavailability of just having the patient swallow the tablet. There is a publication out related to that. I could have to find that. I know that Nick's cringing, but the bioavailability is less than 5% when someone swallows bup compared to up to 30-some to 40% if you take it sublingually or buccally. So why not just try and get the first couple of doses in if you literally have no other option? Certainly it's a little messier, but you could have them swallow it, and that would be a possibility. I've told a couple of other providers that they didn't have it on formulary. So, but I am wondering, could we go quicker? I think that in the future, some of the injectables may have some pharmacokinetics that allow you to give the injectable shot while there's still full opioids in there, so the patients really don't have to do your standard induction. And it'll be interesting to see if that's the case. I don't see any other hands up right now. You want to talk about what? Go ahead.
So necessity being the mother of invention, just to chime in on that, my hospital does not have lower doses than 2 milligram tabs, nor do I have injectable bupes. So for the past year and a half, all of my microinductions have been at a 1 milligram dose. This is the only one I did on a patient who was intubated, but I have yet to have a precipitated withdrawal, even for patients who had full agonist therapy. So I've actually become quite comfortable with the 1 milligram, the split 2 milligram tab, and just giving them half of it. I feel relatively safe that I'm not going to precipitate a withdrawal for what it's worth. I wish I had lower doses so that I had more freedom, but I don't have that. So I've had very good success with 1 milligram.
Yeah, I hear both points. I would just caution, I think if you're going to have a complication from a precipitated withdrawal, it's not going to be in a young, healthy patient. it's probably going to be in somebody with a tenuous heart condition. So those would be the patients that I would be the most careful with. And granted, it's double the dose, but we frequently have patients who feel precipitated withdrawal with 2 milligrams. And so while I hear what you're saying, that 1 milligram you haven't had that experience, I think it's certainly within the realm of possibility. And if it's in the wrong patient and we're unlucky, I think it's the potential for an adverse event. So that's the only reason I would be an advocate for trying to do a slower induction. And I don't know if you've approached your P&T committee about adding Belbuca to the formulary, but maybe that's another option too.
Yeah, you make an excellent point, and certainly you can tell by some of my initial recommendations on this patient that I had trepidation making those recommendations and was concerned about the risk for precipitated withdrawal in this patient, and I was lucky that it didn't happen. So to summarize a little bit of stuff, I did a quick lit search for buprenorphine as sedation because that was a new concept to me. It's used commonly in veterinary medicine, actually. So if you look at, it's mostly in horses, but also in dogs and cats with sort of mixed results. And I only found one formally published report, so that's the next slide, of 3 patients who had ICU ileus related to full agonist therapy, who were all successfully sedated with buprenorphine intravenous. The first, the 62-year-old male who was agitated after a trauma and had an ileus, was maintained only for 1 day. And then you had a 30-year-old woman who was hit by a car with an intracranial hemorrhage and a fentanyl-induced ileus with agitation, who was successfully treated for 6 days with buprenorphine IV. But the one that really impressed me was this 34-year-old gentleman with septic multi-organ failure and a fentanyl-induced ileus who was sedated on his vent for 16 days with buprenorphine. But these are all from 1990, and I think the landscape of opioid use has changed immeasurably since then, and our patients' neurochemistry is really remarkably different. So there is some precedent for it, but I think it's something really worth putting out into the literature a little bit more.
Yeah, thank you. This is a really interesting case. And thank you for joining us as well, Dr. Kurtz. Any other comments?
Thank you for having me.
Questions? Well, we've gone over just a little bit. I'm not going to present the 4th case. I'll save that to next time. We'll start out with that case. It's kind of the classical way we've been doing the microinduction, so a teaser for next week. But again, this is very interesting. We've got one of our PICU fellows here that's interested in looking at buprenorphine use in pediatric population potentially. I think that hospital use of buprenorphine set in settings when to start it is just in its infancy. The new guidelines coming out from ACAM on pain management for patients with opioid use disorder are going to be a primary continue the buprenorphine, which is what our practice is in almost everyone. So you're going to have a lot more need for expertise in the hospital setting, in the ED setting, to help guide the treatment of pain and perioperative management and sedation management and restarting buprenorphine for patients in the ICU in a lot of different settings. And so we need to start getting some of this out in the literature more. There's a couple of abstracts that have been published on the microinduction, in addition to one in the outpatient setting called the Burmese method. That's a full paper. There's another paper coming out in the Journal of Addiction Medicine, and I think a couple of other case series describing microinduction that have been published, but that's really not sedation like you're talking about. That's starting while the full agonists are in place. It's an opportunity to get some stuff out there in the literature, certainly. So if anyone has any other questions or comments, certainly send email. I want to thank our presenters today, Lauren, Nick, and Stephanie, and Dr. Gertz. I appreciate you all participating and submitting cases, and then join us in March for the 3rd Friday case conference again. And if you have a case or want to participate presenting, let me know. Send an email. Thank you.